Hello, this is the first of 3 talks to do on glaucoma. This one's on the classification of the glaucomas. It's to give you an overview of the classification of glaucomas and outline some of the known risk factors for developing it, why definitions and classifications are actually even necessary, and I briefly introduce the 6 randomized controlled trials that tell us how to treat things. And an awful lot of it, or most of it, comes out of this terminology and guidelines for glaucoma, which is the European Glaucoma Society. It's a big document, but it synopsizes everything magnificently. It's really worth the read. You can access it from that website, but if you can't, it's on my website at work, the educational section, if you want to go through it all. So this is an absolutely general definition of glaucoma. Glaucomas are a group of progressive optic neuropathies characterized by slow, progressive degeneration of retinal ganglion cells and their axons. Glaucoma results in characteristic changes in the appearance of the optic nerve head and retinal nerve fiber layer and patterns of visual loss. And I say general because, of course, not all glaucomas are that slow. Raised IOP is long, we all know this, it's been long dropped from the definition, but it is certainly a major risk factor for developing glaucoma. And of course, as we all know, IOP remains the only modifiable risk factor. So lowering IOP does reduce progression and remains the mainstay of treatment. And until quite recently, you couldn't actually claim that. I know we intuitively knew it was true, but you couldn't claim it. And without adequate treatment, glaucoma can progress to visual disability and eventual blindness. The European Glaucoma Society does stress that classification disease definitions are arbitrary. So you don't always have to agree with them. And quite frankly, they often get upgraded and changed anyway. They state that a consensus can only be reached if it's acceptable to most ophthalmologists on both theoretical and practical grounds. And they do go on and say there are conditions where a precise classification is particularly challenging. Now, the example they use is with juvenile type glaucomas, which apparently are very difficult to classify sometimes. But I think of how currently we classify primary open or high tension primary open angle glaucoma and normal tension glaucoma. I think that exemplifies this classification challenge. And in fact, normal tension glaucoma also then exemplifies why classifications are important, because they can drive management options. So the European Glaucoma Society give us this sort of classification, perfectly valid. They break it down into primary and secondary glaucoma, idiopathic or caused by something, and also classified according to the appearance and obstruction of the drainage pathway. And they again have primary and secondary with pupil block and without pupil block, and in secondary they have anterior pulling, example neovascularization, and posterior pushing, lens-induced phacomorphic type stuff. And then they have their juvenile glaucomas, which we don't really deal with in this particular talk. And why is it important to have this? Well, I think it helps us learn. Being able to compartmentalize things, you can learn it in bits and then piece it together later. And I think that does help us learn a lot. But it should also direct and reflect treatment strategies. Unless you understand the process of categorizing things, means you have to have looked at it and figured out how they work, so you can subclassify things as different. And then that then leads on to how you might choose to treat the entities. But for instance, in this particular categorization, they do not differentiate between primary open angle glaucoma or high pressure primary open angle glaucoma and normal tension glaucoma. And I'm going to suggest that at least in the future, maybe they will be considered or could be considered different entities. And that would then perhaps suggest they be treated slightly differently. Now, I'm not saying that's going to happen, but my mind suggests that it's a possibility. And also late onset childhood or early juvenile glaucoma is pretty much the same as primary open-angle glaucoma. It's just totally arbitrary. It's an age bracket. If you read the definition of that, it is fundamentally primary open-angle glaucoma. They put in a couple of negatives. For instance, they say there's no globe enlargement, and that's to differentiate it classifiably from the other forms of developmental type glaucomas. But basically, it's an age cutoff point that differentiates it from adult primary open-angle glaucoma. And another couple of things in here. I mean, there are other things, and there are various things that can push. They've used, just as an example, I have to say, it's not exclusive, lens-induced, that is phacomorphic. But there are also a lot of drugs that will do it, that will actually, well, some drugs anyway, that will push the whole diaphragm forward. And also in there, you've got the pupil block mechanism with drugs. Now, it certainly can't be stuck in a primary. It's not primary. So it's definitely secondary, but it's definitely using a different mechanism to pulling. It is using the pupil block mechanism, but it is as a secondary process. So again, these things are great, they're good, but it's also quite important, I think, to actually consider them yourselves and think about what you're dealing with. So generally speaking, we all know this one. The aqueous is produced by the ciliary epithelium, and it flows through the posterior chamber via the pupil, of course, into the anterior chamber, and then the aqueous exits the eye via either the trabecular meshwork, the normal one, or the uveoscleral outflow. And a balance of aqueous inflow and outflow is essential to maintain, in brackets, normal IOP. So with disruption of the aqueous outflow, it leads to raised intraocular pressure. That's the normal way things happen. And we can have either open angle type mechanisms where there's increased resistance to aqueous outflow through the TM, and that results in a decrease in drainage of the aqueous humor. And then there's angle closure, and there's different mechanisms here, but I think 75% of them is this pupil block type mechanism, where the drainage pathway is blocked, usually by the iris, leading to a decrease in drainage of the aqueous humor and a build-up of pressure in the posterior chamber, pushing the iris forward. They're the normal things. But this mechanism, open angle mechanism here, cannot, in my opinion, explain normal tension glaucoma. In effectively all glaucomas, outflow facility is reduced. But when you do the same tests on normal tension glaucoma, outflow facility isn't actually reduced that much at all. And that sort of makes sense, because if outflow facility was compromised, was reduced, you'd expect the pressure to go up, and it just doesn't. So it makes you think that perhaps there's a different mechanism to the pathology of normal tension glaucoma. And of course, we all sort of know that. There's this whole vascular thing at the back of the eye going on, which we'll get onto later. So it suggests to me that in the future, those two things could well be separated out, that it might be a different pathological process, therefore requires possibly a different classification. And of course, there's also episcleral venous pressure disease, where the pressure there goes up and up and up. And it's not that the TM isn't open to drainage, it's just the backup pressure on the other side is too strong, too great to allow the aqueous to drain through, because it's obviously a pressure-driven thing. And then there are more mechanisms than pupil block as well, which we'll come on to, but in a general sense. So consequences of raised IOP, okay, it's an imbalance between the aqueous humor secretion and drainage. The increased IOP damages posterior structures of the eye, notably the lamina cribosa, and then the lamina cribosa can become displaced, causing a deepening of the cup and narrowing of the rim of the optic disc. The damage to the posterior structures can cause mechanical disruption of axonal transport, leading to retinal ganglion cell death. It's unclear whether retinal ganglion cell death is a cause or effect of glaucomatous cupping. I have my beliefs on it that drive how I review things clinically. But while the site of insult of the optic nerve head is the optic nerve head, the outcome truly is death of retinal ganglion cells. So that's what glaucoma is, it's death of the retinal ganglion cells. Previous thinking considered mechanical and vascular factors as separate causes of retinal ganglion cell damage, but it seems more likely perhaps it's a mixture of mechanical, vascular and genetic factors. But again, back to our normal tension glaucoma thing, there's definitely, one would argue, more of a shift towards the vascular end, whereas perhaps high tension glaucoma is more towards the mechanical, perhaps. So let's have a look at this again. They do state that, this is taken straight out of the European Glaucoma Society document, as most population studies, this is a qualification of how they came up with this particular classification. As most population studies did not differentiate between POAG and secondary open-angle glaucomas such as pseudoexfoliation glaucoma, the following statements apply to both varieties. Here they are labelled as OAG. So in their and I can't get this, right? It doesn't work in my brain at all. So they have OAG, which is simply open-angle glaucoma, which could include secondary things. And then they have high tension open-angle glaucoma and normal tension open-angle glaucoma. But to me, when I say POAG, and I think most of us do this, when I say POAG, I mean high pressure glaucoma. But the way they presented it, and they presented it because of the way the research drove it. The research didn't differentiate between this when they were collecting the data, and therefore they have to create a classification system that reflects the data that they've got. And you know, in the future, more data might come in and they might reclassify it, but that's how they've done it. So for them, open angle glaucoma is both what I call POAG, but they say POAG high pressure glaucoma and POAG normal pressure glaucoma. But believe me, during this talk, when I say POAG, I mean high pressure glaucoma. Okay. And in there is also, you know, pseudoexfoliation and pigmentary dispersion and so on. And that does fall into it as far as they're concerned. And where does ocular hypertension fit into all this? Well, it was originally considered a diagnosis, and indeed, in lecture 3, we'll be talking about, we still can't get out of the habit of diagnosing as ocular hypertension when they're suggesting really it's not a diagnosis at all, it's simply a risk factor. But again, our vocabularies reflect how we think, and we've got to be very careful that we don't muddy the water for people by using terminology that reflects something that the other person might not think. So let's look at some dilemmas with classification. And we'll start really just with the whole normal pressure range. How did we get it? Well, basically they just did huge population-based studies, and they revealed that the mean IOP was 15.5, then took standard deviation as that was 2.6 millimeters of mercury. 2 standard deviations either side of the mean gave a range of 10 to 21 millimeters of mercury. That's how they came up with it. Now, of course, it's not normally distributed anyway, so that straight away muddles up that whole principle. But the point normal comes, it's a statistical definition. It's the normal range of IOP in the human race. It does not necessarily, it doesn't at all imply that outside that normal is somehow pathological. But because we use the term normal, then the leap of illogic came when we assumed that outside that range must be abnormal or therefore pathological. It's a bit like saying a 6'7" tall person, because they're outside 2 standard deviations of the normal range for humanity, must be somehow diseased. It doesn't mean that at all, obviously. It simply means that they don't fall into a normal range of heights for a human being. So that's where the illogic came in, and that's, to my mind, created a whole wad of trouble for us ever since, because as soon as we measured a pressure of 22, we thought, oh my God, it's not normal, i.e. it's abnormal. The other thing about these things is other evidence apart from pressure. And I'm getting back to my bugbear about normal tension glaucoma being a subclass of POAG. You know, disc hemorrhages, for instance, are about 4% of the glaucomatous population will show disc hemorrhages. I think the non-glaucomatous population is about 0.4 or something. But for people with normal pressure glaucoma, it's 40%. Now, okay, most glaucomas get abnormal, or a lot of them have abnormal blood coagulation profiles. Retinal vein occlusion is far more prevalent in glaucoma patients, and vascular risk factors, and low perfusion pressure, which we'll get onto later. But as far as normal tension glaucoma goes, far more likely to have migraine, Raynaud's, other vasospastic phenomena, systemic or nocturnal hypertension, silent myocardial infarct, cerebral infarcts, and so on. And so it does, to me, show that evidence alone would suggest there's got to be something different going on with normal tension glaucoma. Outflow facility is not reduced particularly, and then there's a lot more vascular issues associated with it. So to me, it suggests that at least in the future, we could well be thinking they're 2 different entities. But certainly the whole range of normal, what's normal anyway? Normal for a normal tension glaucoma patient ain't normal. It is truly pathological, whereas a pressure of 26 in someone else, or 28, just because it's outside the normal range doesn't mean it's abnormal. It's actually fine for that patient. So again, they had this arbitrary subdivision into high and low tension glaucomas. They defined POAG as a chronic progressive optic neuropathy with characteristic morphological changes on the optic nerve head and the retinal nerve fiber layer. And importantly here, in the absence of other ocular disease or congenital anomalies. That's important. Progressive retinal nerve ganglion cell death and visual field loss are associated with those changes. And I think in the next 2 lectures time or whatever, we'll talk about looking at glaucoma when you investigate a patient in a systematic way. So for instance, as diagnostician, this means we have to investigate first a thorough ocular and medical history with a full drug litany, past and present, drainage angle assessment, and we need to do dilation for signs of secondary etiologies. It's no point just reading that definition and saying, yeah, that's what it is. It's got to be in the absence of other ocular disease. And then there's CCT. Is that only useful for ocular hypertension, or does it influence the diagnosis of NTG versus POAG? So some people would say, well, if we measure it and the CCT is very, very thin, the patient might not have normal tension glaucoma at all. They have an artificially lowered reading of IOP because they've got a very thin or soft cornea. And indeed, does it even matter? Well, exactly, does it even matter? If you've diagnosed glaucoma, it doesn't matter what the starting point is. You're going to treat it the same under the current situation. But in the future, it might not. If it's truly, and if they diagnose it as NTG, they might say, well, now we're going to treat this in such and such a way. Whereas if it's just an artificially low reading of IOP, then they might treat it in a different way. And secondly, thirdly, with normal tension glaucoma, the Royal College of Ophthalmology say that differential diagnosis may include space invading, occupying intracranial lesions. And it's true, just because it has the appearance, if it's atypical, that is to say the patient's perhaps too young, they don't fit in the demographic or whatever, then they may have to do other tests like MRI scans and so on to make sure there isn't something else lurking there that could also mimic a glaucomatous type optic nerve damage. So the risk prognostic factors for POAG. Risk factors are factors that are statistically associated with it: age, race, IOP, family ocular history, CCT, myopia, and again, ocular perfusion pressure. Prognostic factors are factors associated with progression of that disease, so age, IOP, CCT, disc hemorrhages. And predictive factors, factors increasing the risk of, and included in the POAG definition, is optic nerve head appearance and visual field, and RNFL. So let's go through some of these. Age and ethnicity. Population studies definitely show the prevalence of OAG, that is to say OAG, not specifically POAG, increases markedly with age. And the prevalence is also racial. African Americans are greater than Caucasians. And the prevalence and incidence, Afro-Caribbeans are greater than Latinos, which are greater than Caucasians. So those things increase our risk of having or getting glaucoma. A positive family history is huge. If it's a first degree, so if it's a sibling, you are 4 times more likely to develop glaucoma than a non-glaucomatous person, and if it's a parent, it's 2 times. So lifetime risk of glaucoma is up to 10 times greater in those with a first degree relative compared to those with a negative family history. And it's recognised that genetics play an important role, but the details of it are very, very woolly. It's multifactorial by the looks, and it would depend on a whole lot of things. So because I don't understand genetics very well, I'm not going to linger on that one. And it doesn't really help us the way we treat it anyway. So I'll introduce these 6 studies. They'll come up more in the third talk. But prior to the 6 multi-papered longitudinal studies, apart from expert opinion, there was no evidence treating glaucoma helped. So these are studies that really started in the 90s and really are ongoing. Now, obviously, that doesn't mean we had it wrong. I think most people intuitively knew that reducing IOP helped, but we couldn't quantify it, and therefore had no idea, for instance, of who to treat, how aggressively to treat, and indeed maybe who not to treat. So these 6 studies gave us evidence within parameters. You can only have evidence for something that you've measured. And if you don't measure it, you've got no evidence. It doesn't mean it's not true, it's just you didn't measure it, right? So this will be an ongoing process for sure. But they've given us the basis upon which NICE, for instance, give us our rules of engagement, if you will, in treating glaucoma. And certainly the European Glaucoma Society document synopsizes them very, very well indeed, if you want to quickly read them. Because, as I said, they are multi-papered. If you read every paper, you'd be there for years. And finally, another thing about intraocular pressure, as we've said before, it's an ocular risk factor. Higher IOP consistently is associated with increased prevalence and incidence of glaucoma. And the risk of developing OAG increases per 1 millimeter of mercury. So Caucasians is 10 to 12% increase. So we can quantify these things now. We can put down these stats about the risk factor of IOP. But no, on an individual basis, no single measure of IOP can provide adequate sensitivity and specificity to detect glaucoma. Let's talk about that. Again, talking back to our normal distribution of IOP, if you cut it off at 21, well, just say we went for 3 standard deviations instead of 2. Suddenly we're up to the 99% confidence limit of normality, right? Not disease, normality. And it's suddenly the range goes from the normal range, the statistically normal range goes from 7.7 to 23.3. But if you increase the cutoff point, sensitivity to detect true glaucoma decreases, as many with primary open-angle glaucoma and IOP less than 23 will be missed. So as you increase the pressure cutoff point, the sensitivity of IOP picking it up decreases. But the specificity will improve because fewer non-glaucomatous patients will be incorrectly referred. So if you refer someone with a pressure of 21, there's every likelihood they're normal. If you refer them with 28, it's highly likely they've got it. But unfortunately, one pays off against the other. So as sensitivity goes up, specificity goes down. So again, there's no single IOP measure can provide adequate, and Medscape, it's a very good resource, incidentally. You have to register with it, but it's really worth it. It's an American site, so sometimes when it quotes drugs, they might be different to the ones we can use in Britain, but the principles are all great. So again, using IOP measurement alone as a screening tool for glaucoma is neither adequate nor cost effective. You know, in a case finding scenario, if you have a pressure of greater than 30, then yes, specificity would be close to 100%. But it couldn't be used for a screening service because sensitivity would be rubbish. So if you've got someone sitting in your chair and you do actually measure them at 30, then yes, it's 30. But using it for a screening purpose where everyone less than 30 gets pushed out of the screen, then that wouldn't be a good system. And Medscape beautifully encapsulate this. You know, there's your curves of IOP, and the blue bit is the area that produces a glaucomatous field loss. So we've got range there in the blue there of going from what, I don't know, maybe about 15 up to obviously over 30. But you've got that huge olive looking area where there's no field loss. So pressure is just hopeless, really. And they also do that lovely little pie diagram there where they've got the oculohypertensive group, which again don't necessarily have glaucoma. Then there's the normal tension glaucoma group outside that zone, and then the primary open-angle glaucoma inside the circle of ocular hypertension. Then you've got your general population. So you're trying to get those two tiny little circles there in all that noise. So IOP is a toughie. So really, it's disc ratio versus neural rim examination. And this comes up much more in the next talk. In this one, it came up because it indicates that large CD ratios are predictive of developing a visual field defect. However, cup disc ratios is not clinically meaningful without a measurement of the overall disc size. So if you've got a huge, well, we'll put it this way, we've all got approximately 1.2 million nerves going into our optic nerve. Now, if we've got a huge optic nerve, say 2.5 millimeters, then we've still got 1.2 million going in there, but obviously they're going to be spread out over a much larger area. Whereas if you've got a much smaller optic nerve, then it's all going to look a bit more crushed up. So really, sometimes you can get a CD ratio of like 0.7, but the neural rim might look perfectly healthy, and it just happens to be a big optic nerve. So in these situations, a measure of the optic nerve head size can be very helpful. As I've already said, we have approximately 1.2 million ganglion cells going into our optic nerve. And obviously, logically, if the conduit is a larger diameter, the cup will also be larger, because the 1.2 million nerve endings have to be spread out around a rim that's bigger. So it's important to try to take a measure. This demonstrates that you just get the slit, the height of the actual optic nerve, and you've got a conversion factor to put in there depending on which lens you're using. And so, if you're looking at a CD and you think, my goodness, that's a big CD ratio. But if you then carefully look at the neural rim, you think, well, actually, there's no notches, there's no bayoneting, there's no burring of a circumlinear vessel. And then if you say to them, well, okay, the vertical disc diameter is large, say 2.5 millimeters, then it's extremely unlikely they've got glaucoma. Now, obviously, it'd be sensible to just confirm that with a field plot or an OCT map to make absolutely certain it's within normal ranges. But so long as the fields are full, you're very, very comfortable that this is a physiological thing, and you've made the measurement to prove it. So more of these risk factors though: myopia, moderate to high myopia, greater than 3 diopters, it's a very much higher prevalence of OAG. So myopic eyes, well, they may have connective tissue alterations, making them more susceptible to optic neuropathy anyway. But frankly, from my point of view, they're stretched eyes anyway, aren't they? The whole retinal nerve fiber layer is under a lot of stress there anyway. So I would argue that they're probably just more susceptible to damage anyway. Diabetes and systemic hypertension. The European Glaucoma Society simply state diabetes and BP may be associated with increased risk. However, data from the literature are inconsistent. So the however bit is about episcleral venous pressure as opposed to general circulatory blood pressure. So raised EVP can be associated with really elevated IOP and glaucoma. It's usually secondary to some sort of underlying problem, but it can be idiopathic, familial, or sporadic. And the thing is, it's a pressure-dependent flow. So it's got nothing to do with trabecular meshwork. The trabecular meshwork outflow facility is perfectly good. It's beyond that where the aqueous is going to be assimilated back into the general circulation. And so it's pressure dependent. If the pressure in the venous system is really, really high, there's simply no pressure differential to drag the aqueous out. So the pressure can go up and up and up. And in fact, it's according to a colleague of mine, when I was giving this talk a little while ago, said, it's rare, but also it's highly misdiagnosed. It's not something you leap to straight away when you see an eye looking like that. You look at all sorts of things first, but it can be done down to venous obstruction, retrobulbar tumors, vasculitis actually would be one that would be quite possible, carotid cavernous sinus fistula, and various other things, and idiopathic, sporadic, and familial. So rare, but the pressures would be high. So there is certainly an association between poor optic nerve head blood flow and optic neuropathy, again, particularly with normal tension glaucoma. And we should be, it's easy to say when most of our patients we see are normal, they don't have glaucoma, but be mindful that patients with vascular dysregulation disorders could possibly suggest poor optic nerve head perfusion. It's usually the other way around. You'll look at the optic nerve and think it looks suspicious and then pay more attention to what they've already told you. I have an example of a lady who I took down. I was just doing a normal case history, so I knew she had I knew she had migraine. I knew she had a lot of, she had very high cholesterol levels. She had a few other things like that. I can't quite remember exactly what, but it was only when I then looked at her optic nerve head, and the pressures were only about 12. I looked at her optic nerve and I thought, holy, this is different. So then I went back and actually thought more about her vascular signs that could suggest normal tension glaucoma, because as we say, disc hemorrhages 40%, migraine, Raynaud's, systemic and nocturnal hypertension, silent myocardial infarcts, and so on. And then there's also high prevalence of retinal vein occlusion in glaucoma patients anyway. So 10 to 40% of POAG patients have had previous retinal vein thrombotic episodes. So, you know, there's something going on there, because that's certainly much higher than the normal population. So for community IPs, therefore, a patient presenting with a retinal vein occlusion should also be worked up to exclude the presence of underlying glaucoma. Okay, that's the point that they made. I'm going to say that you're going to do that anyway, aren't you? You're always going to be looking at the optic nerve anyway. So I'm not saying you should do anything more than you'd normally do, to be honest, but you are always going to have dilate. You obviously are going to look at the optic nerve and take pressures and consider the whole picture though. Low diastolic perfusion pressure. I've used this term a few times, and I'll get onto it in the next slide, I think. And it links with systemic and nocturnal hypertension and hypertensive shock and severe blood loss. So let's finally describe this thing, ocular perfusion pressure. The European Glaucoma Society say the association of low ocular perfusion pressure with increased glaucoma prevalence has been a consistent finding in population-based studies. So what is it? Sometimes it's also called diastolic perfusion pressure because it did evolve from a systemic association, not just ocular. So basically, it's simply the diastolic blood pressure minus the IOP. So there's the example. We've got a blood pressure 120/80. The diastolic is 80. We've got an IOP of 16. You subtract one from t'other and you get 64. And a certain author, I forget who, decided that if it's below 55 millimeters of mercury, this is a higher risk of poor vascular perfusion and hence glaucoma. However, the European Glaucoma Society go on to say, because of our limited understanding of this complex variable and of its interaction with potential risk factors for glaucoma, the exact place of ocular perfusion pressure in glaucoma management remains unclear. So they don't really know what to do with it. But again, it just shows that in the future this could become important. It could indeed change the way we treat patients. It could certainly change the way we classify certain glaucomas. But at the moment, it is more of an academic exercise than anything else. So we'll move on to secondary glaucomas. And I want to start with steroids. These are a unique drug family because they're the only drugs that can induce an open angle glaucoma. And like so many secondary glaucomas, which we'll come on to shortly actually, they subclassify them. They have steroid-induced ocular hypertension and steroid-induced glaucoma. Patently what that means is that some people will have it and they don't get glaucoma even though it increases the pressure, and other people will develop signs of frank glaucoma. And obviously it depends on how much you're doing it. If you raise the pressure for a week because you're treating some acute inflammation, it's probably not going to cause it anyway. But so certainly they cause an open angle glaucoma. And I think it is quite important for us all optometrists to think about this, because patients will ring you sometimes and ask the question, you know, how I've been put on a new drug by my doctor and it says glaucoma as a side effect. Tell me about it. Well, guarantee it. every other drug apart from this one will be a closed angle mechanism. So if you've looked and you know their angles are open, you've recorded in the notes that the Van Herrick's 4, then you can quite comfortably advise the patient not to worry. So with steroids, again, with susceptible individuals, they increase TM resistance. So it increases deposition of extracellular material in the TM and inhibits endothelial cell phagocytosis. So again, the pressure starts going up. I am unaware of any predictive test to identify a steroid responder. There may be one, I just don't know. But basically, you have to just clag it in and see what happens. And if the pressure rises, then you know you've got a steroid responder. But they do say it does seem to manifest more in a family history. So, as diagnosticians, though, we must be conscious and investigate, if necessary, these sorts of things. So, for instance, we do need a thorough ocular and medical history with a full drug litany, both past and present. And I think that's, well, I'm big on this. I really think optometrists tend to are fairly poor at taking drug litanies, and they don't really pay much attention to them. They just take them because they were told to at uni, I think. But a history of steroid use must raise the possibility of steroid-induced glaucoma. Topicals, yeah, days. I mean, you can do it in a day. Systemics can be months or years. But for instance, there are anecdotal stories of this. You get someone in, and if you've got a suspicious disc, is it because they've got normal tension glaucoma, or is it because they used to use steroids that you didn't know about, and they had a steroid-induced glaucoma 20 years previously? They've stopped it, the pressure's dropped right down again, and you're muddled up as to what to diagnose this as. And there are stories of people being treated as normal tension glaucoma when they actually never had it anyway. So previous history of steroid response may also temper how we treat things. So for instance, if you happen to know someone's a steroid responder, it may change what you do in the community as far as treating with a steroid for certain inflammatory problems. Or maybe if you're confident enough, you'll treat it, but give them an anti-glaucoma medication as well while you're doing the steroid treatment. So next on the list, PDS and PG. They are technically different. Pigmentary dispersion syndrome is not glaucoma. So you do the pressures and the pressures will be perfectly normal. But it can morph into pigmentary glaucoma. That's when the pressure starts going up. And both of them can potentially go through active and inactive phases. So there's PDS-A, active pigmentary dispersion syndrome, versus inactive. So the classic signs, the triad is basically vertical deposition of pigment on the corneal endothelium, the Krukenberg spindle. But there can be pigmentary deposition within the anterior and posterior segments. It's a concave iris configuration, extremely deep angle. And then because of the depth of that and with them rubbing on the zonules, you've got these classic spoke-like transillumination defects of the iris due to the iris rubbing on the lens zonules, releasing iris melanin. So they're the classic appearances of it. So why active and inactive phases? Well, it reflects the whole pathophysiology of the disease process. Both of them predominantly affect younger people, pre-45 really. And the archetypal patient is young, white, myopic male. In the majority of cases, the severity of both of them decreases in middle age when pigmentation, or above middle age, I don't know, when pigment liberation ceases. And this is really due probably to A, the lens thickening and pushing the iris forward away from the zonules, and also reduced accommodation, so it's not rubbing up and down on the zonules as much anyway. And once they do become inactive, either of them, the signs have been observed to regress and ocular structures regenerate. I've got a patient exactly like her transillumination defects were very pronounced early on, and now I know they're there, but you have to look. Conversion from PDS active to PG active, and this is important for us because this links down to all optometrists, referral on an intent to treat basis. So we're inactive pigmentary dispersion syndrome. The argument is the endothelial cells of the trabecular beams successfully phagocytose particulate load, and they do it so well that it preserves the intratrabecular space as an outflow facility. But with PGA, active pigmentary glaucoma, the trabecular meshwork is dramatically altered. The endothelial cells appear to be lifted loose in PG, and the TM collapses and we have loss of outflow. But the point is, we should be confident to monitor PDS until signs of PG manifest. You know, in my past, I will have seen this stuff, thought, oh my goodness me, PDS, I better refer. And there's nothing wrong with doing that. But fundamentally, the treatment for PG is identical to POAG, right? So if your pressures are 15 and you've got pigmentary dispersion syndrome and there's no other signs of any other sorts of glaucoma, then they're not going to treat it anyway. So there's absolutely no point referring them. You're wasting their time, you're wasting CCG money, and you're wasting ophthalmology time. So monitoring in the community is totally appropriate in the absence of any signs of frank glaucoma. And so referrals should be based on signs of PG, and that's generally, well, that is increasing IOP. So if the pressure's always been 15 and it starts creeping up and it gets up to 20 or whatever, you're thinking, well, actually there's a bit of a change. And obviously if there's frank signs of glaucoma like fields and optic nerve appearances, then obviously they're going to go anyway, aren't they? But certainly PDS, perfectly happy monitoring that, and unless there's signs of glaucoma. So basically the same goes for pseudoexfoliation. We've got the syndrome and the glaucoma. They might sometimes use different letterings to designate them, which is a bit confusing, I think. But anyway, as with PDS, many cases remain undiagnosed, actually. The only time you notice it is if you dilated the pupil and you suddenly see the exfoliation material. And it's invariably routine pupil dilation, which again is another reason why we should all be dilating pupils, of course. You're not really going to see this necessarily. So basically abnormal protein is produced in the body and in the eye, and it accumulates on the anterior lens capsule and also in the trabecular meshwork. So pseudoexfoliation glaucoma is the most common type of secondary glaucoma. Its typical onset's after 60 years of age, and it's often but not necessarily bilateral. Signs include, well, the exfoliation material, and as I've said already, dilation to me is essential. Some people would say maybe recommended. I'd say it's essential, especially for IP optometrists. And again, in the next lecture, we'll see why we should be systematically working through the eye before we make any diagnosis or for referral. We shouldn't just take pressure, look at the optic nerve, do fields, decide it's glaucoma. You know, that's for an IP, I do not feel that that's actually appropriate. And like all chronic glaucomas, it's asymptomatic until field loss becomes advanced. But again, if you've diagnosed it or you've opened the pupil up, you've seen it, but the pressure is only 15, again, perfectly acceptable just to monitor. Uveitic glaucomas, they arise because of obstruction and edema of the TM, caused by inflammatory cells and precipitates and so on. So you can also get secondary scarring and neovascularization of the TM, and angle closure may also occur with synechia forming. And steroid treatment obviously also lead to IOP rises, because you're going to be treating these people with steroids, aren't you? So you need to be on your toes. Symptoms: pain, redness, photophobia, decreased vision. Now, again, if the pressure's rocketing up, and if they've got truly a granulomatous type presentation in the anterior chamber, you're probably going to want to refer. You wouldn't want to be treating that in the community anyway. Signs include raised IOP, right, basically, and it can be linked with a whole lot of usually inflammatory type things. Juvenile arthritis, sarcoidosis, syphilis, and so on. So, you know, there's a lot of things going, and viral, especially if they're chronic, it can cause this sort of stuff, because again, it engenders an inflammatory response in themselves. With simplex and zoster, you know, yes, you've got the acute presentation, but then often if you don't nail it quickly, you'll have this chronic thing with viral antigen in the stroma causing an inflammatory response and so on. So obviously we need to use a topical or systemic anti-inflammatory, because we are dealing with an inflammatory etiology. So you've got to nail the underlying cause. Then to deal with the IOP, you'd use a topical or systemic IOP lowering med. Obviously it would be logical not to use a prostaglandin, because we're dealing with an inflammatory process anyway, so you don't want to stick a pro-inflammatory mediator in there as well. That could logically make matters worse. So it would be more logical to use a different, contraindications aside, to use a different sort of IOP lowering med. And ALT and SLT should be avoided, I would argue, because it's generating heat, and that's going to generate inflammation as well. So Posner-Schlossman syndrome is a rare condition. It's an inflammatory glaucoma syndrome characterized by episodes of very high IOP. They're recurrent. There's not a lot of AC activity. It typically affects young males. So again, in a community practice, it's not someone that wouldn't ring alarm bells with a sort of patient. The pathophysiology is actually unknown. The patients usually present with unilateral blurred vision. So again, young male, blurred vision, you're not going to be thinking anything bad really. Mild eye discomfort or pain, halos associated with corneal edema during episodes, I would argue, of high IOP, not otherwise. So vision can be 6/6 to counting fingers, so okay, that helps me a lot. The conjunctiva is usually white. Maybe there's pupils sluggish, but maybe small KPs, but not a load. AC's deep, no synechii, minimal flare. But at last, IOP during the episodes, I guess, is elevated. So that's going to be a giveaway. As soon as you get a pressure of 80 to 40 to 80, you're going to pretty much refer. Although I suppose problematically, that's only going to be during the elevated zones. You might see the patient when it isn't, so you'd be terribly confused. Treatment is obviously to control the IOPs, reduce the inflammation, beta blockers, and again, prostaglandin is not such a good choice because they have a theoretical risk of exacerbating inflammation, and topical steroids can be used for inflammation. Historically, it's always been thought of as a benign disease. I don't know how it can be, but you know, most patients are treated for attacks and recover without long-term problems. But a number of patients with repeat attacks, even if treated, may show long-term glaucomatous changes in the optic nerve. It's thought that the total duration of elevated IOP, not the frequency of attack, that contribute to the damage. And these patients certainly are candidates for some form of surgical therapy. And with trauma, angle recession. So the definition of recession is pathological withdrawal of tissue from its normal position. Angle recession may be caused by blunt trauma. So trauma can damage the trabecular meshwork, risk of glaucoma increases, 10% risk of glaucoma at 10 years, but it's been known to be 50 years later. Gonioscopy shows is the key to investigating this. I don't do gonioscopy. I'm not very good at it, so I wouldn't be doing this probably. Will be associated with elevated IOP, and I think for all optometrists, the treatment again is identical to POAG. So if we haven't done gonioscopy but the pressure's high, not a lot lost really there. So whether recession is suspected or not, routine glaucoma workup would be sufficient, I would suggest. IOP, optic nerve examination, visual fields. But a note to myself here, we do get a lot of patients in who say they've had trauma, and we may do an initial check and say that everything's fine. We dilate the pupil for retinal detachments and so on. But perhaps we should be thinking more about this. Perhaps someone who's had real blunt trauma, not just the odd knock, but serious blunt trauma, we should be perhaps reviewing them more regularly for signs of glaucoma, perhaps 3 months, 6 months, or yearly. So, closed angle glaucoma categories. Again, this is what we had at the very beginning of the talk. I would add systemic drugs can cause pupil block, so it's not primary. It is caused by drugs, excluding steroids, of course. They can create a pupil block mechanism, secondary pupil block, and also there are other drugs that can cause a pushing mechanism, and I call it an idiosyncratic mechanism. But first, angle closure staging. Apparently, you talk about primary angle closure suspect, where the angle is closing but IOP is normal, there's no synechia and there's no optic nerve damage. Then there's primary angle closure, where the pressure is starting to go up now. It's closed enough that the pressure is starting to go up, but and synechia are present, but there is no optic nerve damage. And then there's primary angle glaucoma, where you're getting the optic nerve damage as well. So the usual mechanism, as we've already said, is where the normal flow of aqueous is disrupted, usually because the iris lens friction in the mid-periphery causes an increased pressure in the posterior chamber, bowing the iris forward, iris bombée, causing rapid and significant rises in IOP. That's the usual, and that's 75% of cases. So when we're thinking about primary angle closure, we're thinking anatomical really. Females much greater than males. Then there's ethnicity, then there's family history, then there's hyperopia. Again, much smaller eyes, much more congested inside there really. Shallow ACs, again anatomical, females much greater than males, and then increasing age, because as the AC becomes shallower as the lens thickens. But then the secondary type ones with drugs, drug-induced iatrogenic stuff, the one is a pupil block type reaction actually, caused by drugs that have almost as a side effect sympathomimetic or anti-muscarinic type effects, and these are both pupil blocks. But then there's also drugs that cause, this is this idiosyncratic mechanism, drugs that cause the ciliary body edema, and the whole thing pushes the whole diaphragm forward. Sulfonamides, topiramate, which is quite commonly used in migraine treatment. And then there's also surgical induced episodes, which we won't deal with. So of course we can't actually know every adverse drug reaction of every drug. They may list off, people like me may list off the common ones, but there's a lot. And patients will ring you up and say, I've got this new drug. You think to yourself, I don't really know this one. I want to know about it. How do you find out? Well, you get yourself onto Electronic Medicines Compendium. And when you're in there, you look up the summary of product characteristics for that drug. So I've got two examples here, topiramate and citalopram. And remember, apart from steroids, all drugs reporting glaucoma as an ADR will have a closed angle mechanism of one form or another, either angle closure, either pupil block, or that idiosyncratic mechanism. So make sure you always have a Van Herrick record on their record. And if they do ring up and you look the drug up, you can say, well, you know, it's unlikely, don't worry, your angles are wide open, it's not going to happen to you. But when you are looking these things up, it does specify all these things. They'll say whether it's very common, common, uncommon, rare, or unknown, and they have a definition. So very common is 1 in 10 people will have that as an adverse drug reaction. Rare, it's 1 in 10,000. So again, it might say it's there, but it's very rare, and you might say, well, don't worry too much, it's not going to be a significant problem. But with topiramate, it does say angle closure glaucoma, and it says mydriasis can lead to acute angle, narrow angle, with the possibility of angle closure. But again, if you've done a Van Herrick's on them and you already know it's recorded, you'll say, yeah, this is absolutely fine. So it's dead easy, dead quick to look a drug up for someone and give them really good advice back to reassure them or possibly caution them. So angle closure signs: you have a fixed mid-dilated pupil, vertical elliptical, circumferential hyperemia, ciliary flush, and due to the ischemia, the iris stromal atrophy may be seen, corneal edema, obviously, blurred vision, and shallow AC, obviously, when you look. The optic discs can look edematous, apparently, but usually the cornea so edematous itself usually can't look inside. So how are you going to treat angle closure? Well, obviously in the community we're not going to treat it anyway, but there's medical management. You do use miotics still. Systemic agents in particular, acetazolamide, Diamox, and you can use topical ones. But if it's bad, you know, you're going to go straight to systemics. So systemic agents, the Diamox is a carbonic anhydrase inhibitor, and it does have some significant side effects. But you'll never remember them. If I wrote them all out, you'd never remember them anyway. And to my mind, as I've already said, it's more important that I think you know how to find it. So again, Diamox adverse drug reactions, we've got a few there: metallic taste, dizziness, weight loss, depression. There are a couple that have been thrown in there. But let's look them up. Undesirable effects. This is on Electronic Medicine's compendium again. And almost all of those things listed, the frequency is not known, which means fundamentally so few people have reported these on a yellow card system as to be almost insignificant. Depression, not known. Nervous system disorders, not known. Eye disorders, transient myopia, not known. So, you know, it's nothing really. There's some, I wouldn't want to be giving it to anyone, but systemically, it's not causing a lot of trouble. And okay, Diamox, when using it systemically, which you do, it can also react with a lot of different things. And I could list all those things off, but again, I think it's just important to know where to find it if you were really interested. You know, again, Electronic Medicine's compendium gives you the full list of things if you really want to look into it. I'm not going to read that out. You can find it out if you needed to. So angle closure management. I'd never thought of this before, but you do need to counsel a patient if you're going to give them things like Diamox to drink additional water. And for urgent interventions, we've got chamber paracentesis, we've got iridoplasty and iridotomy. So phacomorphic mechanisms of angle closure. It's again a pupil block mechanism. As the lens thickens, it pushes the iris forward, and then we create this pupil block with iris bombay and secondary angle closure. And I think in modern Western world, we do see a lot of this. We're seeing patients with gradually evolving cataracts, and then the pressure starts going up. And, you know, it's important, I think, to in an intent to treat basis when you're doing these cataract referrals is to also stress if you do think there is a phacomorphic component going on, because it'll certainly get that patient seen a little bit earlier. And they may decide, rather than just doing an iridotomy or something, to actually remove the cataract in preference and kill two birds with one stone. Phacolytic we should not see. Not in the Western world. Nothing should ever go that far. In other parts of the world, it's less uncommon, we'll say. So it's technically an open angle glaucoma, but it is caused by hypermature cataracts. But the lens loses soluble proteins through the anterior capsule and it obstructs the chamber. So we get raised IOP, lens proteins, and pseudo-hypopyon. And then there's neovascular glaucomas, diabetic retinopathy, vascular issues, branch vein occlusion, ischemic central vein occlusion, retinal diseases, chronic retinal detachments, retinal or choroidal tumours. They'll all basically produce these sort of things. So you've got to be on your guard. I don't think we see many of these things. I think, when you see an eye like that in the right there with all that neovasc on the iris, you're thinking that patient's going to be under the care of secondary care anyway. So neovascular glaucoma mechanisms, the anterior segment becomes ischemic. That leads to the neovascularization, fibrovascular membrane. That overlays a trabecular meshwork. And the angle may appear open at this time, but then it becomes synecheiform, and the membrane then contracts and causes complete angle closure. So within the community, we're never really going to be dealing with this stuff. It's under secondary care all the time, but it's pain, it's rubeosis iridis can be there, it's high IOP, cells and flare, hyphema, conjunctival injection, and the treatment is challenging because it's a long-term chronic problem, and it's obviously the patients allowed things to happen, probably haven't looked after themselves maybe quite as well as they could, to allow this sort of stuff to happen. And apparently the treatment is challenging. I can appreciate that it's challenging because it's clogged up for so many different reasons. And apparently anti-VEGF therapies now offer some hope for better treatments in the future. So there we are, an hour and 7 minutes of classifying glaucomas with some obvious examples in there as well. So you can tell it's pretty complex. That was actually 2 lectures crashed down into one, so I'm surprised we got away with 1 hour and 7 minutes. So the next one will be talking about investigating glaucomas, which is also a long one. So thanks very much for being with me, and we'll see you next time.